To begin with the next session, I would like to invite our moderator, Dr. Ramesh Dorairajan. Sir, can you please unmute the mic, switch on your camera? Over to you, doctor.
Yes.
Thank you.
Thank you so much. So we are starting right on time, and we will start first with Dr. Atik Sheikh. Dr. Atik Sheikh is a managing. Can you hear me now? Can you hear me?
Yes, sir. Yes, sir.
Thank you. Did you hear my last few sentences, or can you hear me just now?
We heard you from saying that Atik is going to talk, sir.
Excellent, excellent. Atik, please screen share and we'll start now. Thank you.
Please open your PDF first of all, sir. Then share. How much time, sir? Each speaker, sir?
We have 8 minutes per speaker.
Okay, sir. Thank you.
Super, Atik. Thank you.
Please unmute yourself.
Am I audible, sir?
Yes, sir.
Yeah. So I'll thank AOS and Ramesh, sir, for this wonderful opportunity to be a part of this lovely instruction course. So I'm going to talk on pre-planning, patient selection, role of ocular surface, and what's new in keratometry. Well, about 30% of our patients presenting for cataract surgery have astigmatism that could be corrected by way of astigmatism correcting lenses. With regards to patient selection criteria, any patient with astigmatism of more than 1 diopter with symmetrical astigmatism and axis 90 degrees apart can be taken up for considering a toric implant. So contraindications include patients where we have irregular corneal astigmatism or patients with whom the astigmatism keeps changing and it is not stable. Unreliable measurements with regards to dry eye and KC are conditions where it is a relative contraindication, but still we can consider having toric lenses with caution. Well, the new kid on the block, ocular surface, which everybody is talking in every webinar, it has a very major role to play in our ocular surface in astigmatism management also. Well, this landmark trial published in JCRS says about 80% of patients presenting for cataract surgery do have significant ocular surface disorder. So what happens is if you use a placebo-based astigmatism measuring device, the astigmatism can be wrong and we can get absolutely haywire values before and after using lubricants or treating the ocular surface disorders. Well, the ACRS algorithm published in 2019 gives us an easy way to get out of this confusion which can be created. Explaining this in detail is beyond the scope of this limited time. So I'd like to go to the final part. Well, it has a questionnaire followed by a series of examination and evaluation where you can diagnose the OSD as visually significant and visually non-significant dry eye disorders. If the patient comes under visually significant dry eye disorders, you have to be cautious and delay the workup by about a couple of weeks and then take up the case. Well, picture courtesy, Ramesh sir. Well, this was a patient with significant dry eye disease, and you can see a drop of 1% CMC before and after taking the images. Well, the clarity of the Myers are totally different before and after. So what is significant or the learning points from this ASCRS study is taking a decade history, slit lamp examination, look at the ocular surface, lift and pull the lid, look for lid laxity, push and examine the meibomian gland secretions. T-butt is a very important test which gives us a lot of clues with regards to how and when to do the ocular surface, when and how to do the astigmatism evaluation. Well, the newer devices like meibography, if we have access, are added advantages. But with this, we'll be able to more or less be able to decide whether we can do the astigmatism evaluation or do we need to delay it. Well, the ever so reliable manual K even now has a role in astigmatism evaluation. So what is important is the keratometer needs to be evaluated at least once a year, and keratometry should be done only on virgin eyes. Even things like a non-contact tonometry or applying anesthetic drops totally spoils the tear film, giving rise to wrong keratometric values. So the take-home message with regards to manual keratometry is do it on a virgin eye. Here you can see applanation tonometry being done, and then we are trying to do an auto K where the Myers seem to be absolutely distorted. The red flag signs in manual keratometry are look for shape of Myers. If the Myers are irregular, wavy, distorted, or you're not able to align the Myers, these are indications that keratometry is difficult. The limitation of manual K is only central K can be obtained and the peripheral cornea is ignored, where our topography comes into play. If we have access to a topographer, we'll be able to analyze the total cornea properly and then do the keratometry. The problem with keratometers is different keratometers take readings at different areas of the cornea. So the message here is if you do a manual K, do not take the manual K values and enter it into your lens star or your IOL master and then do, because the IOL master is designed for K at 2.5 and lens star at 1.7. If the astigmatism is varying between the central and paracentral zones and you do this, we will end up with wrong values. Well, in 2015, when we started this IC, we said that manual K was good enough to do toric implants, and we can do a K by doing topography, and topography gives reasonably good axis evaluation. Just like how physical conferences have become a history, manual K and this technique also is all history now. It all changed with this landmark trial by Dr. Douglas Koch, where he found out the significance of posterior corneal astigmatism, and the Baylor nomogram came into play. So we also evolved, and when we did the IC in 2017, we included the topic of PCA into our talk and said PCA was a way forward for toric implants. Unfortunately, that also is history now. Ever since Dr. Barrett came out with his calculator, which RD sir will be explaining in detail, K values have totally undergone a sea of change. And now what's new in K is the K calculator, which comes with the Barrett's formula, which is free of cost. The K calculator helps us to give the integrated K. That is, we can take K from 3 different devices, say our manual K, IOL master, or our auto K. It calculates the posterior corneal astigmatism and gives us a presumed keratometry, which can be used into the calculator, and it is reasonably good. It gives us the median from these 3 devices. Anything more in K? Of course, yes. In 2019, in ASCRS, we had the pleasure of listening to Dr. Barrett, where he delivered his talk, where he says exactly measuring the K using the swept source-based biometers is even more significant and gives absolutely very good values. The reason being there is no extrapolation done, and actual measurements of the posterior cornea is done with the swept source-based biometers. But what was surprising is these values or these readings are very good with regards to patients who have undergone keratorefractive surgery in future. So 70% of patients have an error of less than 0.5, which is mind-boggling for a patient who's undergone keratorefractive surgery. But however, what is surprising is patients with normal eyes or virgin eyes, even now, the Barrett's predicted posterior corneal astigmatism measurement is perfectly fine and good enough. Well, this may change with time. With regards to keratoconus, the only thing I would like to say is up to 55 diopters, the surprise that we get is not much. Maybe a mild hyperopic shift can happen. So use a proper protocol, standardize everything, and then the bottom line is manual K even now has a role. It can be used to quantify astigmatism. However, with caution, topo can be done to do axis evaluation to detect subtle irregularities in the peripheral cornea. Standard K with PCA even now is good enough for virgin eyes in Barrett's. Total K with the true K with Barrett's is excellent for post-refractive surgery eyes. In 2022, what's new to expect in K? For that, you'll have to wait for our next IC. I'd like to thank Adi sir, Ramesh sir, and Partha sir for this wonderful opportunity. Thank you.
Atik, thanks so much, Atik. That is a very, very crisp and beautiful presentation. And the most important take-home point is that we should, most important that you do all the measurements on a virgin eye. The second most important thing I think is that we all find that things keep changing. Over the last 4 or 5 years, we have found that nothing is static, and in toric lens, especially with toric lenses, things keep changing. So let us see where we are today. My talk is on Barrett's toric calculator, but I should mention this: the EVO formula and the CAME formula in some of the most recent publications are supposed to be slightly 5 to 10% better than the Barrett's toric. So this may become the future. As of now, I'm not using them. I'm still using the Barrett's toric. Now, there are various versions of the Barrett's toric calculator, and they are updated once or twice a year, and the updates first appear in the APACRS website. The older versions are found in company calculators like the Alcon toric calculator, in the IOL Master 700 that some of us have, or the LensStar that we have. So we have the older versions because of delayed offline updates. We don't update our offline calculators. And also in the online calculators for like the Alcon, FDA regulations make it difficult for them to make changes in the site once or twice a year. So this is available. The Barrett's toric APACRS is available online. It's free. Here's a home page, and there you have a drop down where various formulas are there. Barrett toric is a variation of the Barrett's the Barrett's basic universal 2 formula. So this is I have put the same data into 2 calculators. One is the Alcon toric calculator, and to the right hand side you have the Barrett's toric calculator. They give very similar results. Both are asking me to put a T2 lens at an axis of 90, but please note the calculated residual astigmatism in the Barrett's online calculator is 0.07, while the Alcon calculator is giving me a 0.17. What happens is once in a while it will bump up your lens or bump it down, and so it is better to go in for the online calculator. There are 2 things which is of great use in this calculator. One is the K calculator, which helps you to calculate the integrated K. And here you have another option, the predicted posterior corneal astigmatism, which Dr. Atik so beautifully showed. Is if done with the measurements are good and you have a good intraocular lens, 88% of your patients will be within 0.5 diopters post-op. Or you have the measured posterior corneal astigmatism, the measured PCA option. So if you choose the measured PCA option, you get a very simple drop down like this. You can enter the data from one of these 5 options: IOL Master 700 True K, the Pentacam, Gallery, OptoView, any SSOCT device or any Schleim plug device. You can enter the anterior, and the posterior, steep, and the flat K. That's all you have to do. So this is the measured posterior corneal option, which is useful in post-classic eyes, where the relationship between the anterior and posterior cornea has changed. It's also useful in ectatic corneas and thin corneas. It is not useful, like Dr. Atik mentioned, it is not useful for our virgin eyes. For virgin eyes, please use the integrated calculator. So this is the K calculator. You put in the data first, then you press K calculator. It gives you the option of entering data from 3 different sources. We know that the same eye, when measured with different kind of instruments, will give you different K1 and K2. So here we have the option of a topographer, IOL Master, LensStar, Pentagam, Aladdin, Argus, manual, as well as auto K. You can take a choice. Then you can calculate and get an integrated K. This integrated K is then used to calculate the PCA, which the calculator will do posteriorly, and then it will give you the final calculation. So in summary, the APACRS calculator is the latest version. Every other version that we have access to may be a little older. The integrated K calculations are possible with this Barrett's calculator, but not with the CANE and the EVO calculator. Please use the True K function when you have ectatic eyes and in post-classic eyes. That's in summary. So I come back to the CANE formula. There is a beautiful review article last year showing it is far superior. In 10% more eyes, you will be able to get within 0.5 diopter. You have the non-toric, toric, and keratoconus in one simple option. This is the CANE formula. LRIs are an option when the patient cannot afford to have a toric lens implanted. please go online and then type in LRA calculator. It is maintained by the Johnson & Johnson. It is free. They don't own the software behind it. So I use the Donenfeld nomogram. I don't use an APA. So once you enter the K1, K2 and your SIA and the location of your incision, you'll get a beautiful picture. This is a picture of the face. This is the right eye. We are making a temporal incision. In this particular example, it's asking me to make a 70-degree nasal LRI, which you can do with your diamond knife. So this is as far as LRI is concerned. Why do we need customized toric IOLs? Toric IOLs, generally the library which the companies maintain, extend between 1.5 and 6 diopters. And so when you have a patient who needs a higher power, it is still possible. Zeiss, IOCare, Apasami, and many others will make you a customized toric lens to order. And this can give you fantastic results, like this example from Dr. Arulmozhivarman's practice. So this patient is post-ICL. 10 years ago, he had ICL. He had high myopia with a bit of keratoconus, now needing cataract. You can see that he has axial myopia. And you can see that he needs 3.83 corneal cylinder. And using the ZCal, it shows you need a 7-cylinder high-power toric lens. So here, Dr. Arul has put in a trifocal toric lens in this patient based on this calculation. And this patient had post-op uncorrected 6/6 to start with. Dr. Arul has a small group of these very exceptional patients. So anybody in the audience who has a similar situation in the future, please contact him and discuss your calculations with him, and you too can get these kind of fantastic results. There are two, after you do your calculations, there are two ways of marking the cornea. One is a direct manual marking. The second is using an online marker. Both markings will give you good results, like in this study done by Dr. Ramamurthy et al. Published in IJO December 2020. And he found they were equally effective. A systematic review of image-guided lens extraction surgery found that when you do online marking, or if you do a digital marking, you will get a 2-degree more accurate marking. So there is a advantage in going digital if you have the volumes. So with the manual marking, you can get results like this: T4 first post-op day 6/6, T3 first post-op day 6/6 partial. Here you implanted a T6 first post-op day 6/9, no improvement. So how do you do a manual marking? Use a very thin slit. Move the collimated dial on your slit lamp till you get the correct axis. For this patient needed 4 degrees. This is 0. This is 5. This is 10 degree. So 4 degrees is slightly short of the 5-degree mark. Then use a disposable needle. Apply Paracaine and directly mark on the patient's cornea before surgery. This can be done by an associate on the OP or by you before you take him up for surgery. And you can get these beautiful results by doing manual marking also. Many of us in India have started doing this manual marking. Now my time is up. If you have any questions, I'll be happy. We'll all be happy to handle it in the end. I now request the next speaker. Next speaker is Dr. Arul, isn't it? Yes. So Dr. Arul will now be speaking on digital marking and, more important, pearls for doing superb surgery. On to you, Arul.
Yeah, thank you. Thank you, Ramesh. That was fantastic. The two talks preceding were really good. Let's go on to the next one now. I'll start sharing my screen. The screen. Okay. Good. My talk is going to be on surgical pearls and the image-guided surgery. So no financial interest in this presentation. So how do you get surgically excellent results in toric IOLs? You need to have perfect incisions. You do perfect marking. Ramesh has already told you about that. You need to get a perfect CCC, implant the IOL, position it, and then recheck. So let's go one by one. The first rule in the incision making is that you do not induce any astigmatism. So the incision has to be almost square. It should be preferably triplanar. It should be temporal. So it need not be exactly on the 180 degree. You can be 1 or 2 millimeters either above or below. In that whole cone area, you would be astigmatically neutral. you should have an incision that is almost square, properly designed, so that you're not going to induce any astigmatism. It's the first important step of doing toric IOLs. Now, as far as the CCC or the incision, again, you can make a mark to get a perfect incision. This is the instrument that I've designed, which makes a mark on the limbus and about 1.25 to 1.5 millimeters onto the cornea. So it gives you a good template for you to go in, dip in, and get a perfectly designed incision 10 times out of 10. So we've made a good incision. You are perfectly positioned. You have not induced any astigmatism. You probably have not even changed the vector, hopefully not. Now you need a well-centered, perfect capsulorhexis. So it can be done manually by, again, taking a marker of around 5 or 5.5 and using the Purkinje image on the cornea as a mark, making a mark on the cornea. So with that, you can use that template as the marker to make a perfectly centered 5 to 5.25 millimeter axis. Believe me, this particular step is very useful because you don't want the lens to rotate either in the immediate post-op or the late post-op period. For the lens not to rotate, the rhexis should be properly sized. The overlap of the rhexis over the lens should be perfect. So doing this one step is worthwhile. If you're doing image-guided surgery, it makes it a little simpler. You have two rings that are projected onto the surgeon's view. The outer ring would be 5.5, the inner ring would be 5.25. And it's really very helpful for you to make your rhexis perfectly centered. The position of this ring is determined from a picture already taken by the IOL master, which takes reference points on the limbus, designs the size of the rhexis with the picture of the limbus that has already been recorded, and that is projected on to the surgeon's view during the surgery. So now the full markerless surgery, watch, it tells you where to make the incision. As the rhexis is already there, again the ring marker, you can finish the rhexis. The IOL master also takes the reference axis of the placement of the IOL, and that it makes a reference with the limbal marks and gives you an overlay at the end of surgery when you want to switch it on for you to position the lens. So after having done the phacoemulsification, fill up the bag with cohesive viscoelastic. Very, very, very important. You use dispersive when you're doing the phacoemulsification. When you put in the lens, please use cohesive. The lens goes into the bag. The last bit of positioning of the IOL is done after viscoelastic is been aspirated out of the bag. And you align the toric mark on the callisto marking. This makes it very, very simple. Here, please note that the Purkinje images are all overlapping. It's very important. This is important to avoid parallax. When you're doing an image-guided surgery, it is automatic. But when you're doing a non-image guided surgery, please keep in mind that the Purkinje images should be in focus and they should all be coincided when you align your toric lens along the mark. So just coming back in, this is something that you will do when you're not doing a non-markerless surgery. After the surgery is over, the predetermined area, which has already been marked, as Dr. Ramesh said, on the slit lamp, the mark that you make on the cornea has to be thin, not smudged, and long. The axis mark has to come into the pupillary area so that you will not have parallax. Under a cohesive viscoelastic, IOL is injected, placed in the bag. Viscoelastic in front of the IOL is taken out first. The lens is rotated just about 10 degrees short of the final position. All this while, there's viscoelastic inside the bag. You have about 10 to 15 degrees short of your final position. Take out the viscoelastic. Now you'll find the rotation becomes more difficult. That's exactly what you want. You don't want the bag to be inflated so that the lens will not rotate in the immediate post-op period. Take your time, gently rotate it into position. Make sure that the Purkinje images are synchronized, that they are overlaid over each other, and then align the lens finally. In this particular case, I used both the marker, that is manual marker, and verified it with the markerless system, and it coincided. So you really don't need a markerless system to get absolute accuracy. Always immediate post-op, verify before you send the patient back home. When the pupil is still dilated, put the patient on the slit lamp and check if the lens is still sitting in the desired axis. Because most often, the majority of rotation occurs immediate post-op in the first 1 to 2 hours. Once the lens is in position, it's not going to rotate that easily unless the bag is going to get inflated. You have made sure the bag is not inflated by removing all the viscoelastic. So verifying immediate post-op helps you to make sure that the lens is in position. If it is not, re-rotate immediately. Post-operative later rotation, if necessary, can be done after a week or 2 when the bag is shrunk a little bit. So in summary, accurate marking, CCC should be central and appropriate sized, IOL should be in the bag, position after complete removal of visco, avoid parallax. At the end of surgery, avoid overfilling of the AC, verify immediate post-op, if necessary, re-rotate. Thank you.
Thank you for a superb presentation, Arul, and your amazing surgeries as usual. Thanks, Arul. Dr. Jayantan, can I ask you to screen share? Dr. Jayantan is an alumnus of Arvind Eye Hospital and the director of KS Hospital at E Road. He's an excellent teacher and he is also trained in refractive laser and refractive surgery at NN Bangalore.
So is my screen visible, sir?
Yes, sir.
I would like to thank Ramesh Dorairajan sir for this wonderful opportunity and especially for sharing his wonderful videos to be presented today in my talk. Thank you so much, sir. So my talk will be on a toric in special situations. So when I say special situations, in context of a toric well, you will either have an issue with calculation or you have an issue with an implantation. So to start with, the issues in calculation could be either at a keratometry, axial length, or IL calculation point. So the first one is the keratometry. So most of the time we do an automated measurement, and with the automated measurements, the acquisition is going to be static. You have no appreciation of the accuracy of the measured moment. Most of the time it's a printout that comes to us and we see the value and implant an IOL, but we need to validate the measurement before we implant the IOL. So for instance, if you are an instrument operator, as you can see in the first image, the image is very clear and the keratometry values are absolutely repeatable. If you're not an instrument operator, then also after the image is taken, you can go back and check for the image quality and the standard deviation, which is going to be the hallmark of residing a toric well. Right? If the Myers are not crisp and clean, the validity of all the other measurements are going to be diminished in a toric well. So the key here in IOL calculation is the tear film. So when you have a tear film abnormality, it is completely evident in the image, and also the repeatability is going to be poor. As I said, even if you're not an instrument operator, once the image is done, you can go back and check for the image quality and the standard deviation, which is not going to be very good. So completely try to avoid jumping into the calculation of these cases. So in the ocular surface disorder, the dry eye, which is most common, presents with all these one. The first one is a manual keratometry value, where you can see the abnormal Maya, which could not be even aligned. The second one is the lens star image, The image quality is not good. There is increased tear film height. The third one is from the IOL master, the typical tail trail sign, the smudging of the images are seen. The last one is because of dry eye, the patient has got a photophobia and trying to squeeze the eyes. And as you could see, the lid is covering half of the Myers. So the image is being partially taken. So these values are not going to be clear. So an irregular and an unstable tear film will affect the biometric measurement for IOL calculation. The need for ocular surface optimization must be identified and addressed before the measurements were performed for IOL calculation and planning. Right. These are the red flag during the keratometry. We'll just keep it off. The second scenario would be the IOL power calculation. If you know, the toric IOLs are labeled with the cylinder power calculated at the IOL plane. What we calculate is the cylinder power of the corneal plane, and the calculators will give a cylinder power calculated at the IOL plane. This will always be higher than the cylinders calculated at the corneal plane. But this cannot be a fixed ratio. For example, in an eye with a deep postoperative anterior chamber, such as a myopic eye, the given toric IOL will correct a lower amount of corneal cylinder than if it is placed in the normal anterior chamber depth. So the ratio has to be slightly higher than expected. It should be 1.86. The converse happens in a shallow anterior chamber depth, where such as in cases like a hyperopia, the same IOL will correct a higher amount of corneal cylinder than expected. So the ratio has to be 1.29. As been told by Jack Holliday, almost 73% of our eyes are just at the normal range, and rest 26% are falling into a range where it could be an axial myopia, hyperopia, microcornea, megalocornea, or nanophthalma. So we need to be very careful when you are calculating this. So remember, it is not accurate to use a single ratio, that is 1.46, to convert an IOL cylinder into a corneal cylinder, as was done in some of the IOL power calculators. So the next scenario is this patient presented to us for a routine cataract surgery, and the corneal value showed just over a 3/4 diopter, and multifocal IOL was implanted. Patient was not happy because the cylinder was still present even post-operatively. So for the other eye, the patient was counseled, and he had the same just over 3/4 of diopter astigmatism. But to our surprise, this patient accepted a T30 model in the pantoric IOL. And after implantation, the patient was 6'6" and N6. So with this idea, we thought of doing it for another patient who also had a 3/4 diopter, but this patient was not accepting the toric. The reason is the posterior corneal astigmatism. The average power of posterior corneal astigmatism is approximately 0.5 diopter. This is not a fixed value, but rather proportional to the amount of anterior corneal astigmatism. The corneal astigmatism calculated with the keratometric index, that is the keratometric astigmatism, neglects information about the posterior corneal astigmatism. It tends to overestimate total corneal astigmatism in eyes with the rule and underestimate in eyes with against rule. This has happened in the previous case where the first patient was accepting a toric because it was against rule, and second patient was not accepting because it wasn't with the rule astigmatism. So not just the magnitude, also the type of astigmatism matters when it comes to the toric IOL. So the important step to improve toric IOL outcome is to rely on the total corneal astigmatism rather than the keratometric astigmatism. Coming to the irregular corneas, the keratoconus, the first of it. The issues with the keratoconus is that the keratometry is going to be inconsistent, especially when you're going to calculate with different instrument. The measurement is going to be completely different and will be less repeatable because of the irregular astigmatism that is present. And because of the steepness of the cornea, the ACD calculation is going to be unusual, and that will lead to error in the ELP and error in IOL calculation. The visual axis may not be always on the apex. It could be on the slope of a cone. We need to remember that. And the keratoconus will create a negative spherical aberration, for which we need to implant a truly aspheric IOL or a slightly positive spherical aberration IOLs. This is a 42-year-old female with a dense nucleus sclerosis in the left eye with a vision of 660, present for routine cataract surgery. She had 2 diopters of astigmatism, but the axis was irregular. So this prompted us to do a topography, and the patient had a keratoconus. So EKR values are almost normal from 3 to 4.5 mm zone. So it was repeatable and the value seems to be fairly good. So we implanted a toric IOL and the patient had a 20/30 postoperative uncorrected visual acuity. So when it comes to toric IOL and keratoconus, the toric IOL was indicated in mild to moderate non-progressive keratoconus with adequately regular astigmatism in the central 4 mm of the cornea. It is okay to do a toric IOL in a severe keratoconus with a slight irregularity, but you cannot assure the results for the patient. But the patient can be independent of glasses. They can be less dependent on the glasses post-operatively, but care should be taken to select the right IOL at this point. So use a K value from the topography, axial length from the optical biometer, and preferable to use SRKT or a Barrett universal formula has been highlighted by Ramesh Dorairajan sir. The second case would be a post-PKP. This is a 30-year-old male patient, post-PKP status in both eyes with a clear graft. The right eye, he had a dense PCC and a vision of 360. So the manual keratometry value showed a 47.5 at 180 and 54 at 90. So topography was done. All the sutures was removed and the patient's topography was stable for quite some time. And this is the topography right now. And the EKR value showed fairly repeatable values. So the magnitude of astigmatism was taken from the EKR and the manual keratometry. Axis was calculated from the topography and the manual keratometry. So the values are inputted and customized IOL was implanted. As you can see here, the model was T8 and the IOL power was 13.5. We expected to have a slight myopic shift post-operatively. We don't want the patient to have hematopia. So as expected, the patient had a good visual acuity with a 0.75 sphere and a 0.75 cylinder post-operatively, improving to 6.9. The PK, the point to remember here is remove all the sutures, wait for the topographic stability, consider multiple measurements, and a regularity in the central 4 millimeters of the cornea decides the outcome in the patients. Right. So the last of it is the issues with implantation. I just have 2 minutes to go. A stable IOL bag complex is a prerequisite for the rotational stability of the toric IOL. So this is a case where there was a PC dehiscence. So whenever there is a PC dehiscence, if it is small, try to convert that into a posterior capsular rhexis. A posterior capsular rhexis is a must because with the dehiscence, you are trying to implant the IOL and rotate it to the intended axis. There could be an extension of the tear. So once you convert it into a posterior capsular rhexis, the extension is completely avoided. So once the rhexis is completed, if there is a rhexis is good, you can go implant the toric IOL. And the key here is always make sure the wound is completely hydrated in the procedure. Disco is completely aspirated. Make sure there is no vitreous stand. Even a small vitreous stand to the anterior chamber can tilt the IOL and compromise the outcome of the toric IOLs. The last point is the cases where you have a zonular dehiscence. A zonular dehiscence of less than 3 clock hours, you can implant a capsular tension ring. And more than 3 clock hours, never try to implant a capsular tension ring in case of a toric IOL. Go for a Sione ring. But when it comes to Sione ring, the point is like you need to extend the wound a slightly bit, which can actually induce a little bit of astigmatism, but it will be better than implanting a non-toric IOL. So to reduce the chance of cutting the conjunctiva, to spare the conjunctiva, reverse corneal pockets are being done. There's no need for a glue also in a Hoffman's pocket. So the key point to remember here is when you're docking the needle, make sure the PC is not ruptured, because with the dialysis and the open capsule, IOL, placing a toric IOL will definitely not be possible. So once the needle is docked, the IOL is buried under the Hoffman's pocket. And once it is buried, once the bag is stabilized, you can go ahead and implant the toric IOL now. The points to remember here is that make sure the bag is completely stable before you implant the IOL. And after removing the hooks, hydrate all the wounds, make sure the wound doesn't leak, and then there's a collapse of the anterior chamber immediate postoperatively because the toric IOL is going to rotate. Okay, so understanding the signs of astigmatism, adapting the newer technologies, and improvising the surgeon skill will definitely make sure the toric IOL outcomes are much better in even a special situation. Thank you.
Thank you, Dr. Jayantan, for a very nice, exhaustive, but very clear understanding of the complexities involved in some of these troublesome situations. Thanks, Dr. Jayantan. We will take questions in the end. I think we'll have some 15 minutes left over. It is okay if the speakers extend by a minute or two. Next, I request Dr. Nishant. Nishant, can you screen share, please?
Yes, sir.
Nishant Madhivanan is the director of MNI Hospital. He's an extremely versatile cataract surgeon and a refractive surgeon.
Good evening, everyone. Thank you, Ramesh sir, for giving this opportunity for being a part of this amazing team where we have always spoken. And to all the listeners, if you all have actually listened to Dr. Atik talking about how to select a patient, and if you had listened to Dr. Ramesh sir talking about what are all the formulas to be put in, and if you'd have heard or even tried to follow a bit of Dr. Arul sir's surgical excellence, I'm sure that I will not have anything else to talk about for now. And Dr. Jayantan's in special situations have actually covered all the other modalities as well. If you have missed all these talks, I'm just going to give you some tips and hints where you can try to make sure that you rectify and get a good post-operative outcome. So where are all the surprises which can come? One, you will have it preoperative in terms of inaccurate preoperative measurements, inaccurate marking of the cornea, and the posterior corneal curvature, which is not taken into. Intraoperatively, the placement of IOL, the shifting of axis, and retained viscoelastic in the bag. And post-operatively is the main rotation of the lens by itself. So we all know that a misalignment of 10 degrees will actually cause around 30% loss in an effective power. And a misalignment of 30 degrees is a complete re-rotation of the lens where 100% loss of effective power will be there. And for higher power toric IOLs, that is like T9, if it is off by 10 degrees, there'll be a leverage of 1.3 diopters. So even in cases of T2 or T3 lenses, a 10-degree misalignment might be okay, but not in higher astigmatic cases. So what are all the problems? The miscalculation of refractive magnitude is the posterior corneal astigmatism, the pseudo-astigmatism because of the dry eye, the pterygium, and the dystrophies, which are the main causes, and a lot of inflammation of the eye as well. And if a miscalculation of the axial length where the effective lens position of the eye is not perfectly in the center, and non-corneal astigmatism, that is like an IOL if the lens is completely not in the bag, one of the haptics is either in the sulcus, or there is any other macular problems. So how do you evaluate? So the main thing first you have to do post-operatively when you have a surprise is always refract the patient, look for a spherical and a cylinder correction. If you have a spherical correction, there might be some miscalculation with the IOL power calculation. If there is a cylindrical correction, there is also a possibility that along with the miscalculation of the prerequisites, you could have also had an IOL tilt. And the diagnosis by the biometry, the topography, and the OCT and eye trace is very important, because OCT at the normal K value, like what Dr. Atik said before, it was only K value, but OCT guided value of an IOL power calculation is what is the best, which is now, because it takes into the axial length from the fovea of the macula. And ocular surface examination of patient with some amount of inflammation, dry eyes should be treated first, because they can also cause some amount of irregularities as well. What are all the choice of correction when you have a problem? First, I would actually say that if the patient has done both the eyes vision, if OU vision, the patient doesn't have any problem and you are only able to see some amount of torus changes, if the patient is comfortable, always leave the patient alone. That's the best choice. If the patient starts complaining, yes, you have an option of either spectacles or contact lens. And then IOL rotation, as Dr. Arul sir said, I've started using it my hospital as well. Always half an hour after the procedure, look at the patient under the slit lamp. The pupils will be dilated. So you do have the markings as well. You can rotate your slit lamp according to the marking, and always make sure that you check. Because in that half an hour or 45 minutes time, if the lens is not rotated, it might not rotate after 3 days or a week's time. So the first half an hour is the most important and the crucial time. And if there is a rotation when you feel like you want to rotate, you can always go back to the operation theater saying that a slight correction is required topically as well, instead of waiting for 3 days to a week's time and then retaking the patient to the operation theater, which might cause a little bit of scare for the patient. And in high degrees of misalignment between the spherical and cylinder calculation, after around a week or 15 days, you can take a decision whether you want to exchange the IOL as well. Laser vision correction is also an option which is available. For my side, I will say that if it is less than 3 months, a surface ablation can be done. If after 3 months or 6 months, if you feel that there is some amount of residual correction, yes, you can try to do a flap procedure with caution. And relaxing incisions should be accurate. It will be best if we can do femto-assisted relaxing incisions. So what will be the management protocol? Start by evaluating the spherical equivalent. You find an error in the spherical equivalent, you have the laser vision correction or the lens exchange like I told you. What if it is a plano? So you have to determine the prerequisite cause. You have to go back and see what are all the other possibilities. If the IOL position is on axis, and if you still feel that the patient is having some amount of problem with the cylinder, please, you have to show the eye tracing. Yes, there are other modalities like Sirius, which also show some calculation, but eye trace actually, even if you don't have it, I would say that you have to refer it to a center which has, because if you're not sure that the alignment is perfect and your calculation is perfect, and still the patient has, yes, eye trace shows some amount of changes. If at all, you have to make the rotation. And if it is off axis, the only thing is rotate. There is actually a website called astigmatismfix.com where you can enter if you have your preoperative values and decision, you can also enter it and you can see where the axis has gone wrong. And then some investigations such as Cirrus also shows for us to have a target plan, but the best will be the eye trace, which will show if there is a rotation problem. Repositioning, as I told, immediate, see in the slit lamp. If it is less than 10 degrees and on axis, you can try to leave it. If there is more than 20 degrees with the parallax error, definitely one has to rotate it immediately. So after 5 or 6, 1 week post-op, if you find that it is off axis, you should always wait for around 10-15 days, because that is where the bag is starting to get phimosed. So you don't know exactly whether that is going to be the final refraction or it might change. So what Dr. Ramesh has told before is 2 refraction to be done at the interval of 2 weeks apart and have a stable refraction. Once you see that every 2 weeks apart, 2 refractions are stable for spherical and cylinder, then you can plan according to your astigmatic fix or eye trace. And the time of rotation for ideally will be around 10 to 15 days. For some, when you try to rotate, always it is better you consider a CTR, because it will extend the bag and it will be easy for the lens to rotate, because the bag starts to get crumpled after a few days. So in late rotation and high myopes with big bags, always consider a capsular tension ring. With the innovations ahead, yes, we have the measurements from the swept source OCT. As I told you, the Cassia and the IOL Master 700, which shows accurate precision access for the patient. And the IOL calculation of ray tracing and the ORA and the HOLAS intro-op, they actually help in the aberrations and the aberrometer. And the guidance tools such as the True Guide, the Callisto, and the Virion are amazing devices to get a spot-on cylindrical toric lens. So I would like to thank the whole team once again. Thank you, sir.
Nishant, thank you so much, Nishant. That was a very wonderful and a very detailed presentation. Thank you.
Thank you.
I think all the speakers can come online and we'll have a photograph taken, because usually after we finish our session, we have a group photo, but this time it's going to be difficult. While we are having the photography done, can I ask are there any questions from the audience? We have one Dr. Twinkle Kumar Shah, Dr. Bhattacharya, Dr. Shamruddin. I mean, if there are any questions coming up, please do ask us. We'll be happy to answer some of the questions.
I think we are all on screen, sir. So I'll just take one snapshot.
Sure.
Yes.
Done. Thanks,
yes,
Nishant.
Thank
Nishant, while you can type in the questions, I have some questions for the various panelists. So each of us will take turns. You can start first. Nishant, how frequently do you have to rotate your toric lens? For every 10 lenses or 100 lenses, how frequently do you rotate?
So I will say every 50 lenses, I will say 2 lenses I have done rotations.
And what is your numbers, Jayantan?
To be frank, I have not done any rotation till now, sir.
Wonderful. Okay, so I also try to manage, but I have done one, and I have a video of that also. Atik, what is your rotation rate?
I have done 2, sir. One was a calculation mistake, sir. So other than that, I have not had any rotation where I flipped the axis and entered. So that was a mistake on my part.
Yes.
In that case, I had to rotate it, sir.
I think, do you have any rule of the thumb to avoid flipping the axis and implanting?
That is mainly if we see the keratometry value and then enter it into the biometer or the ultrasound, whichever we use, that can be avoided. Usually this happens when our assistant or optometrist does the workup and we see the patient in theater. So from that time onwards, I've always made it a point to see the printout before the order is given to the company. And I ensure that the calculation is done by me and not by the company person or by my optometrist. From the time I've started doing this, I've not had issues. In fact, that was the first case which I did where I flipped and entered. And next day I called Arul sir and said, sir, what did you teach me? Everything is gone wrong. And he identified the way I explained it 30 seconds after into the phone conversation. He said, this is what has happened. Then I went back, saw the case sheet, exactly what I had did. Sir told me that it happened. Sir. That was in 2015, if I'm not wrong. So after that, I've had only one case, sir, which was a big bag. It was a high myope, and that rotated. So which I put a CTR and then did the rotation. That patient, I was able to manage, sir. Other than that, I've not rotated any, sir.
So because Atik has brought into this thing of big bag, is there any cases like we have to look into the white to white also for all these lenses, sir?
Nishan, there is no real answer, but suppose you're having a very large, obviously large white to white and obvious myope, then you have to be more careful about the lens which you choose. Now, coming back to Atik, I have one rule of thumb. Any lens, when the printout comes, I look at it as with the roll, against the roll, or oblique. So if it is 30 degrees to the midline, it is with the roll. 30 degrees plus or minus to the 180 axis, it is against the roll. Anywhere in between, it is oblique. So the intraocular lens that we implant has to follow the same formula. For a with the rule, we can't be putting an intraocular lens which is against the rule. So when you look at the primary axis, you should immediately classify the patient as with the rule, oblique, or against the rule.
Ramesh, this whole flipping the axis occurs because the K1 and K2 are entered upside down. You enter the K1 and the K2 upside down. This is usually a transcription error. So I have the dubious distinction of the largest series. I've done it twice. That goes back 15 years, so I know very well what it is to see. And about rotation, I don't think I really rotated a single toric lens in the last 8 or 9 years. Prior to that, I rotated several.
So which comes back to the point, if you do proper meticulous surgery, we don't have to rotate. Rotation, perhaps in several hundred, you'll have one, but it's a very, very rare thing. It's not common.
I would say, Ramesh, the most important take-home message is, please implant the lens under a cohesive viscoelastic. It costs you a few hundred rupees extra. Don't cringe that. Do that and take it out. It comes out well. You do it under a dispersive viscoelastic. The total viscoelastic doesn't come out of the bag. The bag swells up in the first 4 to 6 hours and the lens rotates. That one single step would bring down your number of rotations, early rotations, probably down to 0.
Very, very true, Arul. Arul, there is a paper from Sri Ganesh's hospital. It was not presented, but I saw the abstract in the free paper session, where they had compared the implantation under air, and so they're doing under BSS. They're doing hydro implantation of toric lenses to
I think
avoid.
it's a fantastic idea. That's a fantastic idea. It takes.
Yeah, so maybe we should think about it, because $1,000 and every 10 or 20 patients, we are going to save about 20,000. In a year, we'll be a few lakhs richer.
Agreed.
So
Absolutely.
we all should think about it. Yes, Nishant, please.
Arul sir, you had rotated with your coaxial. So I use a bimanual, sir. So how I implant is I keep an irrigation on one side and use the dialer. Yeah. So that is okay, right, sir? Or it
absolutely doesn't make a difference. Whatever's comfortable and convenient.
Okay, sir.
Arul, one beautiful part of your video was that you had nicely covered the lashes with a beautiful speculum. And in addition to that, before starting, I think you're using a few more drops of pyodin. I think this will absolutely bring down your endophthalmitis rate to 1 in 20,000 or 1 in 1 lakh. So please tell us some more about the speculum that you're using and who's putting the drop of iodine before you start surgery.
Okay, the povidone iodine goes in the room for the patient about 5 to 10 minutes before the patient is brought into the OT. They put in a drop of local anesthetic and povidone iodine there. So about 4 to 5 minutes after the patient is in the OT. Once the patient is in the OT, before even draping, the whole skin is painted with the 10%, and then the 5% is put into the eye after anesthetizing before draping. So after that, the full draping is done. So of course, as you said, the speculum is very important. The one I'm using is designed by ASICO. A few of the Indian companies have copied it. They're also very good. That goes a long way. And again, after you have finished the surgery and you're sure that the wound is not leaking, putting in another drop of povidone iodine into the conjunctival sac post-surgery is definitely worth it.
Thanks, Arul. Superb, Arul. I think we all should get the ASICO speculum and make sure the lashes don't come into the surgical field. That is really amazing. Can each of us take a poll and tell the audience which is our favorite toric lens? Which toric lens, one or two brands, the most commonly used one and the second most commonly one? Nishant, your top left, so we'll start with you.
Sir, no financial interest, but I've used the Oro toric lenses and the AIOC lenses, sir. Toric.
Wonderful, Nishant. And Jayantan?
So Care Group lenses, because I can customize these lenses, especially when it comes to myope, we can actually customize lenses. So I have the dexterity for using this.
Tell me again, I didn't catch the name.
Care Group.
Sir.
Care Group.
Care Group.
AIOC.
Yes, sir. And so affordable patients, I prefer IQ, sir. IQ toric. So both are stable, sir.
So I'm also using the Alcon IQ toric lenses as my primary toric. I have used various other toric lenses. In my hands, they don't rotate. And for nearly 4 or 5 years, I used to use any visco, including normal methyl cellulose visco, and I used to go underneath, clean it up. They don't rotate, but it makes it so much easier to put Helon in the end and then to implant. It just makes your surgery faster and easier. So that's what I'm doing for the last 2 or 3 years. I'm planning to do hydro implantation and see whether I can save the cost on that.
Yes,
Ati,
sir.
can you tell us what your favorite implant is and why?
Depending on cost, sir, if the patient doesn't mind the cost, the best results I've had is with Alcon toric, sir.
Nishant, you're orotoric or hydrophilic or hydrophobic?
Not sure, sir.
Because they had a S-shaped lens which was hydrophobic. I used it about 7 years ago. Then I stopped because of the PCO rate. I think they come out with the hydrophobic toric also, isn't it?
I've not had PCO from now, so maybe it must be hydrophobic then.
Okay. Arul, tell me your first 1 and 2 most favorite lenses and why, Arul? Arul, you're muted. I can't hear you.
Okay, I have no personal choice at all. My largest number was the J&J, what was the AMO. I love the Zeiss because they give you made to order. I use a whole lot of biotechs, IOCares, Apasami, Orolab, everybody's toric. I have no personal choice. I'm very happy with any one of them. I do believe there's a difference between the quality of vision that you get from a different multifocal, bifocal, or a trifocal from one company to another. But as far as toric goes, I am of the firm opinion it doesn't matter at all. Any toric works very well, so I really have no choice, personal choice.
Nishant, please.
Multifocal toric, sir.
Multifocal toric, again, what happens is to do with the availability. Because I use more trifocals and multifocals, and most often I'm going to do a trifocal toric. Getting the desired lens is very easy from Zeiss, because they are able to give you even so-called made to order in sometimes 2 to 3 weeks. They import it and give it to you. So I end up using, in that kind of a level, if I'm using a trifocal toric, most often it is Zeiss. Otherwise, it's not any personal preference.
Yes.
So one more thing is you mentioned about astigmaticfix.com, isn't it? You have also a Barrett RX calculator. So that will tell you whether you can rotate the same lens or whether you have to exchange the lens. So astigmaticfix.com is very good, but Barrett's RX calculator gives you more options. So that is one more thing that we can keep in mind. Then one method which has been advocated in those patients with high myopia, where you're putting a CTR inside. So the CTR comes in 3 different sizes. And if you choose a large size CTR, it may be larger than the actual diameter of the intraocular lens. So one of the options described by some of the presenters is, you put the CTR but keep a little bit outside. Then you tie one of the loops of your toric lens to the edge of the CTR, to the eyelet. Then you put them both inside, and then you dilate to the correct position. So that CTR loop is tied up and drags and it holds it in position. So I had a myope who wanted of all cases, after nearly 5 years, he wanted a multifocal toric, and because I've operated on his mother, he refused to go to Arul. I normally send off my multifocal lenses. I don't do them. So he wanted me to do. I decided to put a Technis toric because he wanted a high ad. He was a short guy. He wanted to read his phone close up. So I wanted a high ad multifocal, though people advise trifocal. So I put a Technis multifocal lens, and I tied the loop and I put it inside, and it worked out quite well. So that's the only time I've tried that.
Nice, sir.
If there are any questions from the audience, we'll be happy to take it. Otherwise, shall we close the session?
Yes,
And Nishant, any questions from you?
I'm just checking, sir. The questions. No, sir. From audience has not come.
So I have one question to Arul, sir. Sir, when you consider trifocal or bifocal, what level of astigmatism do you consider when you think of a toric bifocal or a trifocal, sir? What cutoff do you consider, sir?
Okay, again, this is a very difficult question to answer with any certainty. You should address any astigmatism if it is over 0.75, if you're putting in a trifocal or a bifocal, whatever. At about 0.75 to 1.25, you can do LRIs and get excellent results, whether it's a manual LRI or if the person is opting for a femtosecond, it's fantastic. Anything above that, beyond 1.5, is better to go for, I would choose a toric. But again, that becomes a cost effectiveness. There would be a patient who is not willing to pay the extra amount. So right up to 1.75 or even maybe 2, I do LRIs once in a while. But where your outcome in long term may be compromised, you may have a regression of about 0.5 to 0.75 a year or 2 down the line, particularly if you're doing a manual. With the femtosecond LRIs, which I've been doing for the last 4, maybe 5 years almost now, it doesn't seem to be as much of regression as you would get with manual. So the question here is, yes, if you want to put it here, above 1, you should do something about it. Below, between 0.5 to 1, you take your choice. So either you do an LRI or you better put in a toric lens.
I think this question was also asked to Graham Barrett in I think it was in San Diego. What he said was, he no longer predicts based on K1 and K2 pre-op. He says all his patients, he puts it up in his calculator. Depending on what the calculator tells you, then he decides. Because like what was mentioned by Jayanthan, no, depending on whether it is a short AC, deep cornea, whether it is a myope, hyperope, we can't really predict whether it needs a T2, T3, or it doesn't need a toric. So he says you put it in first. Even he said, Barrett says he can't predict what the actual final value will be, whether a person will need a toric. So everything he does a toric calculation. After he gets a value, then he can decide. So we can't decide based on K1, K2. We had to do a calculation and then decide about what the residual is going to be.
Perfectly right, Ramesh. Everybody should do every one of the calculations for the high-end lenses on the toric calculator. If the toric calculator says go for a toric, then you decide whether you want to do LRI or a toric lens in. So this is a very good take-home message. Please do all your calculations 100% on the toric calculator, Barrett.
Thanks, Arul. Dr. Shamruddin, I mean, do you have any other questions from the audience? I think we have 1 or 2 in the audience. James, any comments or questions? Dr. Harshul Tak, any comments?
Sir, good evening. So I just joined, sir.
So we have actually finished the course, and if there are no further questions, we'll wind up with this. Is that okay?
Yes.
Yes. Thanks, Arul. Thanks, Nishant. Thanks, Atik. Thanks, Dr. Jain.
Dr. Ramesh, you can still stay on with the course, the next one.
Yeah.
Hi, Tejas, how are you?
Hi.
Harshul, thanks so much.
Yeah. So if you want, I will ask you a couple of questions, but you have to stay for the next course.
Please ask me now.
So Dr. Twinkle has a question, a real question.
No, not the question. The last question, what they were discussing about. They were discussing about the toric IOL calculation consideration. We, at our setup also, we consider all the patient as a toric IOL patients. Unless and until we find out that there is actually no need of any toric, then and then we go for the spherical one. Otherwise, every patient is considered as a toric IOL.
Beautiful, beautiful.
In fact, before we counsel the patient, we do not counsel them on an auto-ref reading. We counsel them only after we have done the measurements. Once they agree for a cataract, we tell them that the packages will explain to you once we do the topography and the IOL power calculations.
We counsel on the base of varion only. We can give a very good idea about the toricity part and.
Yeah, but I don't have a varion. So for me, it is before or after the IOL power calculation.
We are now adding. Sorry, Dr. Twinkle, please tell me.
Sorry, you were muted, that's why.
So our session has come to an end and we are handing it over to the hall. And,
Right.
and we look forward for a very good session from the next presenter, Dr. Harshul and Prasad. Thank you so much.
Thank you, doctors. That was